Hello everyone, let's go straight up to sharing the screen right there. Yep, I have already downloaded the first exam. We are full today of a bunch of MRIs from the emergency. A bunch of them are already delayed, so we can't waste much time. This is a hypothesis, a pituitary gland MRI. I just downloaded the images so I could test if my connection was fine. I haven't had the opportunity to, to properly look at the exams, the images. So this is a 42-year-old male. It says here it's contrast enhanced, and it makes no sense because this is some kind of epileptic seizure case and dizziness, and they ordered a pituitary gland scan. Why? Yes. Oh, it says on a previous CT scan, someone said he had an empty sella, an empty Turkish cell. So it is what it is. So as you guys can see, the cell, the Turkish cell, the pituitary site is right here. It isn't empty. It has a gland inside of it. Also, it's reduced, it's concave, and there is inversionation, inward motion, inward positioning of the diaphragm, and it is a partially filled Turkish cell right there, filled by cerebral spinal fluid. So this is quite common in patients of over 60 years of age. Not so common on such young patients, especially male patients. This is a FLAIR for the skull, for the entire brain, which makes no sense in this case, but it is what it is. Let's just get this over with, and so we can go to the next exam. I'm going to put the T1, sagittal T1 right here. Grab a coronal T2. The positioning of the scan is wrong. It's twisted and small position, but still we can kind of tell. This is the neural hypothesis. Oh, I'm sorry. This is the neural hypothesis right there. There is some heterogeneous bone marrow on the clavus. There is also sphenoid sinus inflammation, thickening of the mucosa, nothing major. This is probably the neuro hypothesis, and the adeno hypothesis is right here. This is quite yes, there is something here. No, I was wrong. This is something of worth of notice. The neuro hypothesis is right here. The rest is adeno hypothesis. The pituitary stem is well positioned and it's properly morphologically normal. And let's get a post-contrast. There is a lot of movement artifacts, probably from the eyes, and sneezing or heavy breathing. So this is a very bad exam to evaluate, but I can maybe I can measure something right here on the right side of the adenohypophysis. Just going to, yes, confirm. It's quite like that. It's another axial useless sequence, and it's all shaky. This really isn't a proper exam to report. This is one of the worst exams I have ever seen in my entire life. Probably the worst exam I have ever seen of the pituitary gland. See, this is just freaking terrible. When you think you have seen the worst exams of your life, you'll be surprised how much people can put an effort to it and make it even worse. Just keep in mind, it can always get better, but it will probably get worse. So it's on the right side. It's ill-defined, heterogeneous, and it has been measured as 0.7 by 0.3 millimeters right there, centimeters right there. It's a late enhancing lesion. It is bright on T2 for some reason. Usually it is. And it's low signal intensity, heterogeneous on T1. It kind of enhances a bit on the margins, and it's enhancing late on if compared to the rest of the pituitary gland. So considering how bad this exam is, we have done a lot. We have done much more than we are supposed to do. The pituitary stalk right here, it's a bit shifted to the left, and the lesion is on the right, so it makes sense. Let's describe the lesion and go to another exam. Um, Point 0.7 by 0.3. Yep. Slight shift of the pituitary stalk or stem. How is it called? I can't remember. I just remember hastes hypophysaria in Portuguese. How is it called in English? Is it stalk? Stem? It's stem, not stalk. Pituitary stalk. Yeah, the pituitary stalk is slightly shifted to the left. Okay, we are done here. This is probably a microadenoma, a pretty small benign tumor of the pituitary. If it's less than 1 centimeter, 10 millimeters, we call it micro. If it's over that, we call it macro adenoma. And if it's exactly 1.0 centimeters, we measure it again. So we are done here. That's clear. And download the other exam. This is a MRI angiogram of the neck, arterial MRI angiogram of the neck. I'm downloading. The images are about to get to us. Just going to grab my template. I have a template, of course, because having templates for mostly anything help us out a lot to make our work faster, as much as sipping my coffee also helps a lot. This is a huge exam. For some reason, this exam is comprised of over 3,500 images. I have no freaking idea why, but it is what it is. I am just tired of complaining. I ain't complaining once again about this. I just hope I can download the freaking images as much as anything else. So how's the stream? It seems the stream is healthy. No one is on. Just going to pop out chat. I'm downloading the images as we go. Let's see, it's coming. It's about to arrive. Just going to leave chat right here so I can see if anyone joins our stream. If you haven't already, hit that like button and consider subscribing to the channel. Share this live stream with friends, family, anyone that might be interested. It helps a lot. It goes a long way on helping YouTube understand my content. This channel's live streams and videos are of relevance to the community. So please, it's easy, it's cheap as free. Just help out. I really appreciate it. So a few seconds and we are going to be able right there to analyze. Yeah, they did stupid amount of useless sequences. I just want the freaking angiogram. Give me the angiogram. The angiogram sucks. Yes, the only sequence they should have done, they didn't do because stupid. And it's so shaky, it's useless, can't be read. Let's see if there is anything that can be of use here. No, this is just a stupid and useless exam, can't be read, can't be reported. So it's has been sent back. Now I'm going to grab a lumbar spine. Downloading the lumbar spine. This is a 69-year-old male patient and it says he has pain. So lower back pain, old age, Mayo, all that good stuff we are used to see here. There is really nothing new. I just grabbed my template for old man's spine. There is a little tiny mild left-sided scoliosis. I guess this is a fracture. Seems like it. Seems like a fracture right there. Yes, this is acute. There is a partial collapse. This is 2, 3, 4, 5. No. This is a transitional vertebra right there. Is it L5 or S1? I'm quite sure this is D12. So this should be L1. So it's L1, L2, L3, L4, L5. So this is transitional S1. So we have to start from there. So the surgeon can guide himself all the way to the fractured vertebral body. There is no edema on the STEER sequence. So this is a node fracture. It has healed already. So this is just a chronic collapse. Are there any signs of edema? No signs. No signs of edema, just chronic disease. This is probably due to trauma or osteoporosis. Arthrosis, facet joint, severe facet joint arthrosis, thickening of the yellow ligament. There is vertebral canal stenosis, mild, yet another site of stenosis, and of course the technician. Yes, technician did this on a T1. I don't know why. And this is, oh, there is a T2 right there. T2. So I can say nothing. So it's all right. It's just there. We have a bunch of extrusions. We have 1, 2, and 3 extrusions from L2, L3 to L4, L5, and L5, S1, 3 extrusions, severe arthrosis, some vertebral canal stenosis, and in old age, vertebral collapse. So let's see. Also, there is diffuse hypertrophy and fat substitution of the perivertebral muscles. Just this is chronic denervation and old age all together. So osteophytes. Let's describe the transitional vertebra. It's S1. It has a almost complete intervertebral disc and a bunch of anomalous joints between S1 and S2. I can say it's S1 because this is the last rib. So this is L1. 1, 2, 3, 4, and 5. So this is S1 and this is S2 as far as I can tell without a proper full spine scan that shows me C2. If I can see the second cervical vertebra, I can properly count from up to down and be sure of which segment this actually is. If I don't, I just look for the last rib and call the last rib D12. Since then, I can go counting from up to down until I figure out what this is. This is not 100% what I'm supposed to do, but it is 100% what I can do in this case, because this morphology clearly shows some kind of malformation, some kind of fusion, partial fusion, or failure of proper spine segmentation right there. So this is a hypoplastic facet joint right here. This is an anomalous joint right there with the processus transversalis, left processus transversalis or transverse process, and this is a smaller than normal, a hypoplastic intervertebral disc. So this is a transitional vertebra for sure. So S1 is transitional. And of course, as soon as the patient has some kind of complaint and has a transitional vertebra, it's quite common, almost certain, that he is going to have arthrosis at these sites. Excuse me, like that. That is arthrosis. So this is quite a painful transitional vertebra. So there is also an increased curvature right there. His lordosis is increased, which is also a sign of chronic degenerative disease. That is diffuse modic 1 and 2 changes on the vertebral plateaus. I can tell old fracture, of L2. This is 3, 4, and 5. Não, eu tô gravando. Volto daqui 1 hora. So this is L2, L3. Okay. This is L4, L5, and L5, S1. So we have 3 extruded discs right there. And we have already stated there is some kind of vertebral canal stenosis there and there. Yes, mild vertebral canal stenosis. L3, L4, no, it's L4, L5, and L5S1. The intervertebral foramina are fine. There is diffuse hypertrophy of perivertebral musculature. So let's just summarize it to make it easier for the referring physician to read. Extrusions right there. Osteoarthrosis of the facet joints is severe, and there is that vertebral canal stenosis right there. It's there, it's done. Let's go to the next one. Clear. Next is brain. If you guys are hearing a child scream and cry, it's my youngest. I'm home and he is in a bad mood today. I don't know what to do. Children are like that, so I'm pretty sure you guys can be much more patient than I. I'm just ignoring it as of this time. If it gets any worse, I'm going to have a few words with him. He is only 8 and he is in a bad mood today. Oh, this is awful. It says the patient is 43 years old, it's a female, and she has some kind of difficulty to walk and has had a seizure May this year and has a very severe headache, and it's awful. I don't know what this is. The scanner sucks. It's a very old low field scanner. It can barely do a diffusion weighted sequence, but this is such a huge lesion. I think we can handle it. Let's just be overly patient and work out each sequence at a time so we can properly make a diagnosis. It's a huge lesion. So this is the T2 effect of a stupid, useless diffusion weighted sequence. This is the shaky and useless diffusion weighted sequence right there. It's bright. Do we have a ADC map? No, of course not, because reasons. Oh, this is the ADC map. So the ADC map is also bright, so there is no proper diffusion restriction, not much than the adjacent parenchyma, so let's forget about it because it sucks. It's also all freaking shaky. This is a huge lesion right there, full of vascularity. Right there, this is a bright tumor, brighter than the cortex. It's extra axial. It's outside of the brain on the frontal-parietal region on the right. It has exuberant vessels. It's kinda homogeneous, brighter than the cortex on the FLAIR, brighter than the cortex on the T2. It has a broad base on the pachymeninges, on the dura mater. It exerts a massive effect, a massive mass effect over the parenchyma. There is a midline shift to the left. There is also a deformation, a mass effect on the ventricular system. It's one of those differentials we have to do with meningioma in a early age group. This is most probably a meningioma. It could also be a hemangiopericytoma, which is a solitary fibrous tumor of the pachymeninge of the dura mater. It can also be, less commonly, a single metastatic lesion that happens to be extra axial, but I highly doubt it because it's too big and too solitary. So there is almost a vascular pedicle right there, which is quite common on these hypervascular tumors. It's mostly solid and it has apparent vascularity, which should be much more apparent if we had a SWI sequence, but this is a very old scanner. It has only gradient echo. They tried to do I don't know what they did here, but they did. I don't know what this is, but whatever. And they did this, which helps no one. Oh, they have contrast enhancement. It enhances all over the place. It has some sites of probable necrosis because it's huge. Should be a fast growing lesion because this patient is way too young. This is a axial T1. T1 is quite similar, a bit lower in signal intensity if compared to the cortex. They did it again, this stupid useless sequence, and they did a subtraction, which also makes no sense. And this is the post-contrast phase. I'm just going to grab it, put it here and see. Of course, they didn't finish the post-contrast acquisition because who cares about the cerebellum? Cerebellum, it isn't even part of this exam, I suppose, right? This is why you just stop the contrast enhancement phase on the hair and cuts off half the cerebellum. That's how you do it. That's how you do a proper scan of the brain. You just do half scan. You do half scan of the brain because half scans are just as good as the entire scan of the freaking brain. How stupid can this man be? Come on. Just there are double the sequence they are supposed to do. All of it sucks. All wrong. Double the sequences. All wrong. All shaky. All mispositioned. Yeah. Let's just report this crap and go over to the next one before I pull my hair out and spill my coffee. It's over 7 centimeters, 7.6 centimeters. It's frontal-parietal on the right, maybe temporal too. The midline shift on the axial view is about 0.5 maybe. It's 0.4. So it's 0.4 to the left. And that's what we're going to do. This right there, this is due to ependymal transudation. This is ependymal fluid. This is liquor. This is ventricular fluid being pushed out of the ventricular system into the periventricular white matter. This is a clear sign of intracranial hypertension due to the mass effect caused by this tumor. This is why the patient complains so much about a major headache. So let's describe this tumor in this piece of crap exam. Let me read what I just said. Frontal-parietal temporal region. Ampla base dural. 7.6, 6.9, 4.8. So there is deformity of the supratentorial ventricular system. Midline shift. There is diffuse effacement of brain sulci on the right. This is edema. This is it. Not talking about the hippocampus because it makes no sense. Let's see if there is signs of acute bleeding. No acute bleeding, just necrosis. And this is it. Let's just summarize the scrap and move on to the next one. Let me just grab the proper name for this. It's a solitary fibrous tumor of the dura mater. Let me just see here, just to be histologically accurate. Yeah, solitary fibrous tumors of the dura, right there. Which is also hemangiopericytoma. One type of hemangiopericytoma is one kind of such tumor. This is it, and we are done. Thank God. It wasn't so hard. I was just pissed off because people just can't do a proper scan. As always, I'm old, have gray hair, and still I can't really deal with such cases without being pissed off all the time. It is what it is. Let's move on. And this is a T1 sagittal view. This is a 35-year-old male. He says he has memory loss, headaches, and has passed out at least once. So this is a scan for such complaints. Okay, there is a anomalous bright signal right there on the right dural sinus of the posterior fossa. This is the transversal sinus. This is the sigmoid, and this is the start of the internal jugular vein. This is normal, and it also shows on T1 there is some kind of disturbance right there on the flow of blood inside those sinus. It kind of messes up also the final posterior portion of the superior sagittal sinus. This could be just slow flow, but this is looking oddly, awkwardly bright to me. I'm not happy with that. So let's grab a T1. Yep, the T1 also as bright as it gets. Let's hope they did a contrast enhanced phase and a proper SWI sequence, or maybe a gradient echo. T2 didn't help much. T2 is right there. See, also bright. Let's see a diffusion. The diffusion also bright, which is odd. This is a quite fast, a really fast sequence. Slow flow wouldn't just show up like this, so this is a very possible case of thrombosis, dural sinus thrombosis right here on the right. Oh, that is a SWI, freaking shaky sequence. Really like this? Come on, man. This is just freaking stupid. Oh, crap. They did it a bunch of times and still they did it wrong. Let's see the coronal view. Yes, coronal view, it's bright. Right there. There is no volumetric axial post-contrast phase. Of course not. Of course there isn't. Why should it be there? Why would they do the proper sequence? If they can just do the crappy, stupid, useless sequence. Of course. Yes. Oh, crap. People are this stupid. People are really this stupid. Yeah, I'm just pissed off. Just report this crap and move on. I'm going to suggest it's a thrombosis and also suggest a proper angiogram because reasons. Yes, stupid crappy exams. Come on, it's just stupid. So this is it. Reported suspected thrombosis, but the exam is of such a terrible quality I can't properly tell, because all the sequences that would make me sure of it are absent, shaky, malposition, or improperly done. So I said go do a venous angiogram of some sort for a proper diagnosis. I can only go this much. It's up to you guys now. So this is a 71 female. She is it says she was moving during the exam, and they still did a couple of angiograms, of brain angiograms in this patient, a arterial and a venous phase intracranial angiogram. I'm pretty sure we aren't going to be able to report this, because if the technician says the patient was shaking during the exam, it means she was probably trying to get up and run, because the usual is a bad looking exam, and when the technician feels like apologizing for it, it's even worse. It's as bad as it could possibly be. So let's see, it's a huge exam, but it's going to take less than a minute to arrive, less than 40 seconds now, a bit over 30 seconds. Oh god, this is so tiring. This is so awful. Let's go. 15 seconds. Let's see if we can report this crap. If not, we're going to move to the next one and see what we can do. It's here. Let's open it up. Oh, it's come on, man. The skin is sideways. It's an MRI. This is not a CT scan, and the scan is sideways and incomplete. It's sideways and incomplete. It's twisted to the side and freaking incomplete, and for some reason it was acquired on the coronal plane. Why would someone do a venous angiogram of the brain on the coronal plane? I'm just going to send back the venous angiogram. Exame. So let's see if we can report the freaking... Oh, of course, you don't need to image the entire carotid arteries. You can stop right there, because, no, why not? Just, yes, of course. No No freaking way. So it's done. Next. Can't do. There is a reason for this. These exams are stuck on the queue. They are stuck because they have been returned by other doctors for sure, because half the exams I have open here are impossible to report because they are of awful quality. They are just make believe, they aren't really real exams, so someone must have sent them back already, and they are doing a second try to see if somebody else on the next shift would be courageous enough to report them. So we have reported half of these exams and we are returning only the other half, so there is progress. This is a very old and low quality scanner, usually a 0.3 or 0.5 Tesla scanner. I'm sorry, a low field crappy scanner. Spine scan right there. Arthrosis, moderate facet joint arthrosis, thickening of the yellow ligaments, diffuse liposubstitution, fat infiltration, and atrophy of the perivertebral muscles. The roots are fine. That is degenerative disease of the discs. There is 1, 2, and 3 extruded discs right there. Mild or moderate arthrosis. Let's see, what can we say? Mild arthrosis. Is there stenosis? No, not enough to call it stenosis. And there is, of course, all those modic 1 and 2 and maybe 3 changes on the vertebral plateaus. I have a template for this. Let's move on. Let's go to the next in a few moments, because the queue is freaking full. 2, 3, 4, and 5. There is no transitional vertebra right there. S1 is S1 and L5 is L5 as much as we can tell. L5 S1, there is no protrusion. There are no signs of vertebral surgery. This patient is 84 years old. 84 right there. So L2, L3, L3, L4, and L4, L5. There are extruded discs that all that good stuff we know. No stenosis, just plain old extruded discs, bone edema, arthrosis, thickening of the ligaments, the supporting ligaments, that degenerative disease of everyday reports. So it's done, it's sent, it's summarized. It's pretty much what we are supposed to do. There is a scan that has been sent twice. It says there were missing images, so they send over images. It was done on the 7th of October. Yep, 7th of October. I don't know. Really? 79-year-old female, 79. It's a brain scan. It's downloading. Is it downloading already? Yes, it is downloading already. I have to download both entries. I don't know if there is anything different. I'm just going to try to understand. It says she has gone through a bunch of surgeries. She has stuff in her mouth, metal stuff in her mouth. She has has chronic hypertension. She had a hemorrhagic stroke and is prostrated. She is restricted to being bedridden. This is probably one of those major brain diseased patient. So it's done, it's here. Let's move on. Let's see what we can tell. Oh, of course. Check this out. It's shaky. That is a hematoma right there. They made it again and it's worse. Coronal. This is hemorrhagic. A hematoma. This is diffuse atrophy of the hippocampus, MTA4 for sure. Diffuse and severe white matter disease, severe hydrocephalus, supratentorial hydrocephalus, diffuse and major signs of brain atrophy, just right there. That is acute blood right there. Yes, Fazekas grade 3. Severe hydrocephalus, diffuse brain atrophy, a few small lacunar infarct. Of course, you don't need to image the entire cerebellum because it makes no difference, right? The technician surely likes the bone better than the brain. And it is what it is. For saving a couple of seconds, you can always do a terrible twisted and usually only partially use a full exam right here. Atherosclerosis of the brain, intracranial vessels, and it is what it is. Old hemorrhagic deposit right there. Some signs of old subarachnoid hemorrhage right there, and the acute hematoma right there. I say it's an acute hematoma because it's bright on all sequences and it has a very easy to see margin of blackness on the SWY sequence. Let's just see. Of course, I can't see enhancement here because it's bright on T1 and it's going to persist bright on the post-contrast phase. So unless there is a proper subtraction sequence, I'm going to ignore the post-contrast phase in that case. See, you can make it worse. You can make a volumetric sequence and still cut off half the cerebellum. Of course, why not? But you image hair. Hair is fine. Cerebellum is useless. This much useless images from the hair all the way to the bone, but the cerebellum you can miss. It's all right, right? right there. You don't need to image the entire cerebellum, not the brainstem, nor the first few segments of the spine. No, the hair is okay. Hair, skin, and bone are important. Brain, not so much. Of course. As every single time. Every single freaking time. I don't know who teaches these people to do exams, but they all teach the same wrong. It's always the same crap. It's just freaking stupid. I'm especially grumpy today. So, superior frontal gyrus and the prefrontal, superior frontal gyrus on the left, right there. So it's contrast enhanced. Just going to grab a template because reasons, why not? A Fazekas 3 template, why not? A Fazekas 3, and I'm going to describe the intracranial parenchymatous intraaxial hematoma on the left frontal lobe. It's 1.9 by 1.8 by 1.7 centimeters. Fine. So there is old subarachnoid hemorrhage on the frontal and parietal lobes. We can see it right there on cerebellum and right here. See, this is old, the same as this, just old. This is probably due to some kind of hypertensive emergency sometime in the past. There is severe hydrocephalus and diffuse thickening and atrophy of the hippocampus. Yes. It's done. Acute cerebral hematoma on the left. Severe hydrocephalus, and we are done. I'm just going to copy this and paste it on the other entry because this is duplicated. I don't know which one is going to be printed and sent out to the clinic, so we are going to send both of them so we don't miss anything and we don't get someone asking for us to send over yet again the same exam. So this is a male patient, 53 years of age. He has pain on his lumbar spine, and a lumbar spine has been done. A lumbar MRI has been done. So no, it's not. It is a lumbar spine. Yes, there are some sacral region. Yep, that has a painful motive right there. Oh my god, I'm so sleepy and grumpy today, guys. As sleepy as it gets, as tired as I could ever be. And the stream health is fine. We've been up for about an hour. Guess I'll be here for another hour, so we can properly report a few more exams. And I feel like giving up since I woke up today, but as you guys know, MRI scan won't report themselves. So this is a T1, sagittal T1. Fat is bright, liquid is black. This is a T2, non-fat saturated, because fat is bright and liquid is also bright. This isn't a proper weighted sequence because fat is brighter than liquid. It should be the other way around. If it's properly weighted, if the scanner is properly calibrated, if the sequence was properly done, the liquid must be brighter than fat. If it's the other way around, just like this, it's wrong, and we are missing disease. Some kind of disease won't be properly seen. I can see right here there is a spondylolysis, a fracture, and a pseudoarthrosis of the isthmus of the facet joints, both facet joints of L5. So this right here is a arthrosis right there, a pseudoarthrosis due to a fracture. This is quite painful. There is degenerative disease right there. Let's make it more apparent. If we had a sagittal fat saturated sequence, we could do it, but we haven't. We have none. They just didn't do it because why? Why do a proper scan if you can do it just like crap? If you can do it like crap, do it like crap, right? Just this. Yeah. Why do it properly if you can do it just wrong, right? It should make sense. And of course, I don't need to scan the first segment of the spine because it means nothing. It's not supposed to be scanned. No, you can start off from L2 and forget about L1 because reasons, right? And this is just, oh crap. Of course, this is stuck on the queue. Who in proper sense would report this kind of exam right there? This is so wrong, it hurts. So freaking wrong, it hurts. There is thickening of the ligament, there is arthrosis, there is hypertrophy of the perivertebral muscles, there is no proper protruded discs, just degenerative disease. There is some kind of degenerative disease right there. I can't really tell if this is modic 1 or 2 because we have no fat saturated sequence. They forgot about it. They forgot to do it. And they sent the exam over and told the patient it was done, and now they want a report. This exam was done on the 4th of October, 5 days ago, and I'm pretty sure it has been returned to the queue at least 1 or 2 times because it's incomplete and as poorly done as it could be, or even worse. So let's just turn it over with a half conclusive report and whatever. I don't know why people do this. It's harder to do it like this. It's easier to make a proper exam than to make such a crap scan like this. Just stupid. Just stupid and useless. But whatever. This is it. Nothing much here. Just incompetence and laziness. So this is two MRI scans of the same patient, cervical spine and lumbar spine. Let's go. Pain. She has pain in her spine. Okay, 65 years of age, female patient, 65 years of age. Let's see if we can do a oh crap. Yes, hyperextended neck. The worst way of doing a scan, and of course you don't scan the entirety of the sagittal view because reasons. Why would you do a proper scan if you can do a crappy one? So this is diffuse, severe. Oh, it's incomplete. It is incomplete. It is indeed incomplete. I'm going to return it. Exame incompleto. Right there, incomplete. T2, there is no sagittal and the axial view is incomplete. It is incomplete. Let's see if it is complete or incomplete. It is incomplete, of course. Why not? Also incomplete. It's malpositioned and incomplete. Of course, why not? This is a arterial neck angiogram, MRI angiogram of a 80-year-old patient for some unknown reason. Coffee? Is there coffee yet here? Is there coffee still? It is. There is coffee here. Great code. Coffee. Check this shit out. Come on, man. Come on. Oh, crap. They made... No, I don't believe this crap. I don't believe it. Come on. Oh, yes, they made a contrast enhanced face. As shaky as they could, but at least it's contrast enhanced. And the vertebral arteries Are they imaged? Are they? Yes, they are included on the images, and there is diffuse atherosclerosis right there. The field of view is way too big. Resolution is way too awful. And it's all shaky as much as it possibly could be. But, you know, it is a second phase here. It's a mixed up arterial and venous phase, which helps no one. Just going to put an axial MPR here and see the aortic arc is fine. Subclavia on the left is fine, on the right is also fine, right there and right there. Origin of the carotid arteries are of usual morphology. Vertebral artery on the right is right here from the brachiocephalic trunk, and of course the left comes from the subclavian left artery. Its tortuosities. Their tortuosities are prominent. There are no signs of ostial stenosis, just a very poorly done scan. Let's follow up the vertebral arteries. No signs of dissection, nor any significant stenosis, just plain old tortuosity. So let's look for the common carotids. Common carotid arteries, right common carotid artery right here. Where is the left? The left common carotid arteries goes loopy, loops like crazy on the left, then goes up. It will become carotid bulb. It's right there, carotid bulb. There is some kind of plaque or right there, so plaque. It's of no significant obstruction. It's less than 50% for sure. If you compare here, this is the proximal internal artery. Let's measure it. 0.7. And this is the narrowest. Let's see. Narrowest right there. And it's 0.5, maybe 0.6. So this isn't of any concern. It's just irregular and less than 50% obstructed, as much as this side too. External carotid arteries are fine. And yeah, this is just plain old atherosclerosis and tortuosity. No signs of a stenotic lesion of importance. So let's grab a template. A template for a arterial neck angiogram, MRI angiogram. And we're going to say that every single vessel is tortuous. Right there. carotids and vertebral arteries. So there is some atherosclerotic plaques on the common carotid arteries and the carotid bulbs, but there is no significant, no stenosis bigger than 50%, larger, more more severe, or I'm just too sleepy. I'm sorry, guys. Just summarize this. There is there is no actual proper stenosis. See, the proximal internal carotid artery is right here, and the site of stenosis is right here. If you compare this to this, it's almost the same. So this is the NASCET criteria that we use in digital angiograms. So this is the standard to see if there is proper stenosis. See, this is the internal carotid right there, and this is the bulb. This is the internal carotid, and this is the bulbs. It's quite the same, so there is no stenosis over 50%. If it's less than 50%, it's of non-importance. So that's what we summarize about. And away it goes. So another brain scan. And it's a 37 female patient, 37 years of age. They did a brain scan with contrast enhancement, and the motive is none. Oh, it's a headache. It is a headache scan. Scan for headache. So let me grab a normal template, copy and paste. It's almost here. Take a sip of my coffee. Open up and do a quick assessment of this scan. Just assessing the scan right there. Yep. Sagittal T1 is fine. Axial FLAIR fine too. Remember, FLAIR is a 2-2 weighted sequence plus a inversion recovery signal that makes normal fluid black. So if it's bright, it's disease. Nothing bright, no signs of disease. I'm going to grab a diffusion weighted sequence because why not? diffusion looks fine. This is diffusion. T1 sequence right there. Yep, T1 axial view is the same as this, just on another plane of acquisition. Fine. This is for the hippocampus and the mesial temporal lobe regions, the amygdala, the amygdalian amygdala, the brain amygdala, and the hippocampus, the para-hippocampal gyrus or gyrus, and the dentate gyrus or gyrus. I think it's gyrus. I don't know. You guys tell me in the comments below. Since no one is actually watching any of these live streams, I'll probably never know. But if you are watching this, be so kind as to hit that like button and subscribe to the channel. Let's try to go to reach the mark of 100 subscribers. We are at 85 after 3 months of content creation and battle at 3 months of war against the algorithm, trying to figure out how YouTube works. And I assure you guys, it's not easy to keep posting and have absolutely no impressions on anything, just because with no clear justification. So hippocampus are fine. This is an SWI, a susceptibility weighted image, all freaking shaky, full of movement artifacts, but there is no sign of old bleeding nor mineral deposits. Post-contrast volumetric axial T1 3D acquisition is normal, although it's also blurred by movement artifacts. They did it once again and it's still as bad as the first try, so crap. T2 is also shaky. T1 is fine because this is a much quicker sequence and I can't really tell any disease out of these images. No, I cannot. This is a fine and normal exam. Finally, let's grab another one. 93-year-old male patient. They did a contrast enhanced brain MRI scan because there is some kind of hydrocephalus. So because of hydrocephalus, they did a scan on this patient. Okay, fine. I can take that. I can take hydrocephalus. I can do it. It's almost here. It's here. So let's see. There is a axial FLAIR, a axial T1. There is severe hydrocephalus, severe white matter disease, a bunch of small lacunar brain infarctions right there, right there. That's quite common at his age. Mesial temporal regions are quite preserved. Let's see a diffusion weighted sequence. Diffusion weighted sequence is fine. T2 should look awful. There is lacunar infarction right here. Some lacunar infarctions all over the brain and the brainstem and the cerebellum. This patient is almost 100, a century, 100 years old. So what did you expect? That is diffuse arteriosclerosis of the intracranial arterial vessels. Of course, it couldn't be different in that. It couldn't be the opposite, because this patient is almost 1 century old. It's just twisted to the right, to the left. I can say this is a MTA3 hippocampus. Is of course hippocampal atrophy as much as the rest of the brain parenchyma. They did a contrast enhancement phase. We're going to scroll over the MPR. Why not? Axial MPR here. Let's see if something odd enhances. No enhancement on the sagittal view. Let's grab a much better view, which is the axial view. Real men only need axial sequences. Sagittal, coronal, and MPR are for children. So I'm no children. I'm old. My hair is gray. And I'm quite tired. But still, axial view is more than enough. Let's see coronal view, because why not? It's here. Let's see if we have any anomalous enhancement. No anomalous enhancement. No whatsoever. So this is just an old man's brain. Old man's brain. Lacunar infarctions, infarctions, ischemic spots, old ischemic spots. All over the brain. Severe hydrocephalus, severe microvascular white matter disease, severe atrophy of the brain in the hippocampus, MTA3 and Fazekas 3 as well. And we are just summarizing it. And we are going to be done arteriosclerosis of the intracranial arterial vessels. Of course, why not? Just finishing it up. And we are done here. We have been up on this live stream for over 1 hour and a half, and I'm going to wrap it up here, guys. Thank you so much. Please hit that like button, subscribe to the channel, and share this live stream with people you know enjoys diagnostic radiology. I'll be sure to be online once again, most probably on Friday, and maybe also on Sunday if I can. So thank you so much, and I'll see you guys in the next one. So long.